I'm Ed Grant, and I'm the chairman of the Department of Radiology at the University of Southern California in Los Angeles. And the lecture that I'm going to be giving today is entitled Measurements in Cerebrovascular Ultrasound, and it's part of the overall course that was held here in the first morning session for the SRU meeting in 2007, which is essentially devoted to the exploration of measurements in various parts of the body with ultrasound and how they're performed. Today I'm going to be speaking about measurements in cerebrovascular ultrasound. Before beginning the actual measurement discussion when it comes to ultrasound, I think it's worth talking about some of the measurements that were originally used in angiography. Basically, if you think about this, most patients who are having an ultrasound are having it because there's the possibility of their undergoing carotid endarterectomy. In this particular case, then, ultrasound really is the decision-making modality to send the majority of patients either to surgery or not. In the past, this was largely based upon angiographic measurements, and as such, there were large studies that have been reported in the literature, large multi-center studies that have been reported in the literature, determining what the success rate or improvement in risk for stroke is following endarterectomy, basically validating the surgical technique. The largest of these was the NASCET study, the North American Symptomatic Carotid Endarterectomy Trial, in which 70% or greater lesions proven by angiography were considered the surgical threshold. Remember, these were all symptomatic patients. The other large study that was done in North America was the asymptomatic carotid artery study, the ACAS study, and for reasons that are beyond my ability to understand, the authors of this study chose 60% or greater lesions to send to surgery, and again, this dealt exclusively with the benefit of endarterectomy in asymptomatic patients. Both of these studies showed that there was improvement with endarterectomy when with regard to stroke reduction, but the amount of stroke reduction in the 70% or greater lesions in symptomatic patients was really quite dramatic, 17% over 2 years, whereas, and it's worth keeping this in mind, the ACAS study showed an only about 5% stroke risk reduction over 5 years. So if you think about those two studies, it's important to remember that the outcome of those patients, or the risk reduction with regard to stroke, is extremely different in those two groups. Now, the reason I bring these studies up is that the original measurements by which patients were sent to surgery were based on angiography. It's also important to remember that all of the Doppler thresholds that we used and continue to use are also based on a comparison with the gold standard, and that gold standard in the vast majority of cases has been the angiogram. It's worth pointing out that there are therefore two different methods of actually measuring the angiogram. The older method, and some people have called this the University of Washington method, is shown on the right, and in this particular case you can actually see that the residual lumen is measured and compared to the original lumen of the vessel. Now, remember, the problem here is that the original lumen is unknown to the angiogram because you really can't see it. So in this particular case, your neuroradiologist has to go in and estimate where the original lumen was to arrive at a percent stenosis. Now, this may actually more truly reflect the degree of stenosis, but unfortunately it's fraught with a huge amount of inter-observer error, as you might imagine. The NASCET method, which has been applied not only to the NASCET but also to the ACAS study, and in fact at this point even the European study, this is the study shown here, the ECST study in Europe, has actually gone back and reworked their numbers as well along the lines of those used in the NASCET trials. So I think something to keep in mind that's very important is that at this particular point in time, almost all authorities would agree this is the method by which we should be determining the degree of stenosis, assuming that the gold standard for all Doppler measurements is in fact the angiogram, and it is or has been in almost the majority or all studies that have been done. It's important to remember that the NASCET method is the one to which you would have to compare your Doppler values when it comes to actually choosing thresholds for 70 or 50 or whatever percent lesion. If you can imagine, comparing the Nassett method with the old method would give you very, very different degrees of stenosis. And it's important, again, in thinking in terms of your thresholds being based upon a gold standard such as the one shown here using the Nassett method. Now, in thinking in terms of Doppler measurements or ultrasound measurements in the carotid arteries, one of the first and foremost things I think that's worth talking about is the use of Doppler parameters. What parameters do we use to actually try to estimate the degree of stenosis based on velocity? And in looking at the literature over the years, I've been able to find no less than 15 different possible Doppler parameters and ratios that people have used. But that aside, I think there are probably 3 or 4 that are in common use today. By far and away, the vast majority of laboratories will measure the peak systolic velocity. This is very easily reproduced, commonly used, and in fact is required as a parameter by all accrediting bodies. Now, a second, and I think very, very important Doppler parameter is the systolic ratio. In this particular case, you compare the peak systolic velocity in the ICA with the peak systolic velocity in the ipsilateral CCA and arrive at a ratio. Now, it's very important to point out that when you do make this ratio, that you take your common carotid artery measurement 1 to 2 centimeters proximal to the bulb. If you take that measurement more proximally down toward the clavicle, your ratios will not be correct because the normal patient actually demonstrates a decrease in velocity as you go forward in the carotid artery. So again, if you take it from the part of the carotid that's not where the original numbers were derived from, you may actually find that your ratios are way off. So very, very important that you have consistent measurements in the CCA that are taken about 1 to 2 centimeters proximal to the bulb. The ICA, obviously, you will continue all along the course of the visualized ICA and select the highest peak systolic velocity, assuming that that would be where a stenosis would be if one were present. Now, the beauty of using the ratio is that essentially you're able to use the patient as their own gold standard, and in some cases you may be able to identify patients who lie outside of the expected peak systolic velocity values. Now, a third very commonly used Doppler parameter, and one that we do use in all of our patients, is end diastolic velocity. There is evidence from the older literature that this may be good for differentiating particularly high-grade lesions from others. Now, in looking at the ability of the peak systolic velocity and the systolic velocity ratio to determine greater than or less than 70% lesions, this is a graph, an ROC curve from our own experience, from our own laboratory. And what you can see here is that essentially the ROC curves for these two techniques, these two parameters, are absolutely interchangeable. And so what this actually tells us is that statistically, one of these parameters is just as good as the other. But unfortunately, if you think about it, one of these patients, rather, are not statistics, and therefore individual patients are best served by combining peak systolic velocity and, in my opinion, the velocity ratio. And again, what you're trying to do as a diagnostician is to integrate all of the various parts of the Doppler examination, such that one is not simply a cookbook number that you plug in based on a chart. So what you're trying to do here, or what I would recommend that you do, is the two primary parameters that I would recommend is peak systolic velocity for the reasons I already gave. Then look at the grayscale and the colored Doppler ultrasound parameters to get an idea if the plaque burden actually is in sync with the degree of narrowing estimated by the peak systolic velocity. Finally, I would then bring in the ratio and, of course, throw in the ICA end diastolic velocity as well. The good thing about the ratio is that it serves as an internal check when patients may have peak systolic velocity values, as I mentioned, that are really not representative of the extent of the disease. And probably the most common group of patients in whom you will find this are those in the carotid group who have poor cardiac output. Remember that atherosclerosis is a systemic disease. If you have it in the carotids, likely you're going to have it in the heart and elsewhere. So many of the patients that we examine for the carotid actually will have poor cardiac output because of their concomitant atherosclerotic cardiovascular disease. In these patients, for example, you may find a low or normal peak systolic velocity and then find that the ratio is actually elevated. In those kinds of patients, then your idea is to put all three of those parameters together and try to arrive at a final diagnosis. So the higher ratio versus a low peak systolic velocity, if you see the low peak systolic velocity diffusely, and then one area where you actually see that the peak systolic velocity is focally elevated and that the ratio is focally elevated, this should give you a good clue as to the fact that there is significant disease in that area. There are other reasons why the ratio may be better than the peak systolic velocity. Again, statistically, it all pretty much evens out in the wash, but for a given patient, it's important to pull together all these pieces of important information. Now, one of the things that we are asked, if you noticed in that first slide, we are oftentimes, I think, asked to do the impossible, and that is to estimate the degree of stenosis using Doppler to a very, very fine amount. And basically, I've been doing this for a very long time, and I think most people would accept the fact that, or believe, that Doppler is actually pretty capable of estimating the degree of narrowing of a given vessel. And certainly I think it is true that the average Doppler velocity value, peak systolic velocity value, does increase in proportion to the degree or percentage of angiographically proven stenosis. Unfortunately, if you look at any one degree of stenosis as measured by angio and compare that to the Doppler velocity numbers, you'll find that for any given degree of stenosis, there's an extremely wide range of Doppler velocity values. Most labs, for that reason, don't try to report a single percent stenosis value, but in fact report in relatively wide strata. And actually we went back, and I'm going to talk a little bit about this, and the question that had come to my mind is, what is a reasonably wide, if you will, strata when you report out your Doppler percent stenosis values? Are very wide ranges more realistic, or can you get down into very tight ranges, or in fact should you not use ranges at all? Because most of the Doppler studies that have been done simply look at differentiating patients who lie above or below a certain percentage of stenosis, rather than actually trying to grade them. So another question then is, how well do these typical strata that we use perform? Well, if you look at these images, I think there's a patient with a peak systolic velocity of 184 centimeters per second. You would probably have no problem, or most people would have no problem, estimating that this would actually be a mid-range, or in the case of the strata used by our lab, a stenosis in the degree of 50 to 69%. And you can see here on the NASET measured angiogram that this in fact did equate to a 61% stenosis. Likewise, here's a different patient. You can see an area of calcium with shadowing posterior to it. You can see intense aliasing, suggesting to you that this actually represents a high velocity or high grade stenosis. In this particular case, you can see that the peak systolic velocity is 377 centimeters per second. Again, I don't think anyone would have difficulty saying that this clearly represents a greater than 70% or high grade or surgical lesion. And again, we are confirmed here by the angiogram showing an 82% stenosis using the NASET methodology of measurement. Well, we actually went back and in a study that we did, looked at a large number of angiograms and compared the degree of stenosis on the x-axis with the velocity. And I think, as most people would expect, you can see that as the degree of angiographically measured stenosis increases, so does the average Doppler velocity. The thing that I think is very important to point out, however, if you look at the error bars around that average or mean velocity, you can see that they're extremely wide. So again, for a given degree of angiographically determined stenosis, there is a wide range of possible Doppler values that will fall in with these patients. If you look at this, this is one standard deviation. You can see very easily and very immediately that this overlaps very, very heavily with its neighbors, telling you that there's no way that Doppler can really differentiate tight degrees of stenosis. In fact, if you look at this, you can actually see that not only tight degrees of stenosis, but actually in this case, pretty wide variations or strata of stenosis. So we actually went back, upon constructing this chart, we actually went back and looked at our Doppler values just to see how well we actually did. This seems like a very simplistic thing, but it's something that actually very few people had tried to do or really tried to evaluate seriously. We used less than 50, 50 to 69, and greater than 70% stenosis measured angiographically as our typical reporting strata. These are the strata that were recommended by the SRU and are the strata that I would recommend you use in your laboratory. Basically, we chose peak systolic velocity numbers and ratio thresholds that are really in keeping, I think, with average numbers. These were actually validated angiographically in our lab, but they're very similar to the recommended numbers for the SRU. And what we discovered was that, again, this is probably best case scenario. This stuff was actually all validated against angio. What we actually found was that the lesser lesions, those less than 50%, those without hemodynamically significant lesions, we did reasonably well. We identified about 91% of those. Also, patients with lesions greater than 70%, again, reasonably well, almost 87%. But look at the mid-range group here. You could probably flip a coin and do equally well, if not better, in fact, than at least the peak systolic velocity. Ratio wasn't a whole heck of a lot better either. So what this tells us is, and it's reflected in those very wide standard deviations, is that breaking down your Doppler diagnosis, even into gradations as wide as these, is fraught with problems. So what Doppler is very good at is differentiating patients into two groups, above 70, say, or below 70. But in fact, as far as actually grading the degree of stenosis, we really don't do very well. And I mean, one could actually say, well, if those guys knew how to do a Doppler study, they'd do better. My bet is very few people could do much better than this. It's just the nature of the beast. Now, this is not to say that we should not continue to stratify, but what this does show is that even the widest of stratifications is fraught with problems. I think that for the referring clinicians, it's important that we and they, as much as possible, realize the problems with Doppler as far as the ability to actually tightly represent or characterize the degree of stenosis, that there's major limitations, but that in fact the clinicians really do need to have some sort of number to hang their hat on. And I think that this kind of stratification corresponds to the levels chosen for operative intervention in the NASCET study, and it makes a reasonable amount of common sense to use these kinds of numbers, even though fully knowing that there are drawbacks to this and that there is a great deal of lack of accuracy in that mid-range. Now, this is all based really upon the fact, if you look at this histogram, this shows a very similar thing. You can see that the majority of patients luckily fall over here, and these are basically less than 50%, are essentially normal. But you look at the blue, which is actually those patients with greater than or equal to 70%, you can see most of these lie to the right, but in fact, in the area in between, that there is a very wide range of Doppler values for those 50 to 69% lesions. Now, that said, I think one of the other issues that's always been the source of a great deal of confusion in ultrasound is the choice of Doppler thresholds. I really think this is probably the biggest source of confusion in carotid diagnosis. And if you look at the literature, you can find almost any number you could imagine has been applied or recommended as a Doppler threshold for a certain degree of stenosis. And over the years, people have tried to figure out why this is, that there's such variation in the literature. And early on, people talked about quote-unquote, intra-laboratory variation, basically saying, well, the machines are not consistent, you scan differently than I do, so we all have variations, and that's why there's so much difference in the literature. And I've looked at the literature and personally think that that's not the reason. And I think the real main reason, although there is certainly intra-laboratory variation, but in my opinion, the vast majority of these apparent differences in threshold recommendation have to do with the use of differing statistical methods to arrive at the threshold, and specifically frequently the desire for increased sensitivity versus specificity. It's interesting that also, I think it's worth pointing out, that most of the commonly used thresholds are actually based upon pre-NASET studies. And again, going back to what I said in those first slides, you really should probably use a threshold that was actually based upon a study that was performed after the NASET trial, 1993, because of, again, the gold standard's always going to be angiography, and you could see comparing those two angiograms that if you used the older method, that would probably greatly affect the degree of stenosis for the same patient estimated by angio. And if that's your gold standard, it will also change the Doppler thresholds that will be found statistically. Now, this is part of a chart from the article that we published in Radiology as part of the SRU Consensus Conference. And it's very cluttered, but basically, to explain this quickly, if you look at this, you can see that there is a huge number of articles that have been written, and this is only part of what's in the literature, a small part of it, but there's a large number of articles that have been written out there recommending Doppler thresholds. But what's important is that the thresholds are simply all over the map. And rather than trying to crane your eyes into that rather cluttered slide, and I only show that because of the clutter, these are some representative numbers. One of the early papers post-NASET was one by Greg Mineta, in which he actually recommended a velocity threshold of 325 centimeters per second as your operative number or your threshold number for a greater than 70% stenosis. And if you look down the list, you can see that the numbers are just all over. Carpenter at 210, Neal at 270, and this guy named Grant at 175. So the variation in the literature is just tremendous. And since most of us don't really have large numbers of angiograms through which you could come up with your own thresholds, as we did, it's important for us to know how to choose a number from the literature. And again, going back, people have said, oh, well, these variations have to do with this so-called intralaboratory variation, basically saying your technique, your equipment, just simply may be different than mine. And as I said, Doppler is a rough form of estimation of velocity, so there is a good bit of inter-observer variability. But in my own opinion, when you look at the literature closely, I think what you arrive at is the simple fact that these variations usually have to do with the statistical methodology that's been applied to the raw ROC numbers. Now, if you look at the literature closely again, you will find that the majority of authors actually chose peak accuracy to determine their threshold number. And of course, accuracy is, we love to be accurate. Radiologists want their tests to be as accurate as possible. Unfortunately, accuracy only tells you coldly how many times you're right when compared to a gold standard. It unfortunately does not take into account whether being right or wrong is important. So there's really no clinically predictable effect of only using accuracy. And what's particularly interesting, and I think it's best showed in this ROC data, is that accuracy really starts out, if you choose a very low threshold, 125, as you increase your threshold to ridiculously high amounts, what you see is that the accuracy really doesn't change a whole lot over that very, very wide range. It goes from about 89, peaks here at about 94, 95%, at about 200, 225 centimeters per second, and then falls off a little bit as you go to these ridiculously high thresholds. Well, why is that? How can that possibly be? Well, the reason for this is simply that if you can simply differentiate patients with less than 50 from greater than 50% stenosis, basically normal versus no hemodynamically significant stenosis, that will comprise the vast majority of the patients in your lab. Now, in the VA where we did these studies, we had a lot of severe vascular disease, and even there, the percentage of patients was well less than 20%. Who had any abnormality. For that reason, you automatically start off with an accuracy of 80%. Then you throw a few more percentage points in there and boom, you're up to 90. So really, accuracy is probably not one of the best ways. In fact, it is definitely not the best way to choose a threshold. But again, as I said, many of the papers published in the literature did just that. This actually kind of shows the distribution of the peak systolic velocity. And again, if you choose 150 centimeters as your cutoff, you're going to pick up the vast majority of these patients who are essentially normal, less than 50% stenosis, giving you an automatic accuracy of about 80%. And throw a few other good hits on there, and your accuracy can easily get up to 80 or 85 or 90%. So really, peak accuracy is not at all a good way to determine the degree of stenosis. Or recommend a threshold, probably better stated. Now, sensitivity and specificity, as I mentioned, do have a direct clinical association. Sensitivity, remember, is the number of patients with a disease. As an example, in this case, lesions greater than 70% stenotic in the ICA that are correctly identified. So how many of patients who were proven to have 70% or greater lesion does a specific threshold yield based on Doppler peak systolic velocity, or ratio for that matter. Specificity is essentially the opposite. That's 1 minus the percentage of overcalls. Basically, specificity equates to the number of overcalls. And remember, each of these will have a clinical effect. So what you're really doing, and this is a far more reasonable way to look at choosing a threshold, you're weighing the number of false positives versus the number of false negatives that you are actually going to accept when you choose a threshold. Unfortunately, as most of us are aware, there is an inverse relationship between sensitivity and specificity, so you simply can't win. Now, how does that work? Basically, if you think about it, if you have a procedure such as an endarterectomy that produces a great benefit, you probably never want to miss one of these patients, or you don't want to miss a lot of patients who would have a huge benefit, such as patients with greater than 70% stenosis who are symptomatic. For that reason, you want to maximize your sensitivity and probably want to choose a low threshold. Conversely, if you have a procedure, in this case, again, endarterectomy, that really only yields a small benefit, you probably want to be conservative and raise your threshold, which would equate to increasing your specificity. Who would these patients be? Well, if you think about it, the symptomatic patients between 50 and 70% stenosis have about a 5% risk reduction in stroke over several years. Likewise, as I mentioned before, the ACAS, the asymptomatic patients who have greater than 60% lesions, again, only a 5 to 6% risk reduction in stroke over 5 years. These patients minimally benefit from the endarterectomy. And in fact, at the VA, for example, where most of our patients had bad multi-system disease, it was very unusual to actually consider doing an endarterectomy on an asymptomatic patient. Again, all you need to do is increase your surgical risk by 1 or 2 percentage points, and statistically, you're probably not doing your patients any great favor. So what I'm saying basically is that in these procedures where there's minimal benefit, one could be justified in siding or being on the side of increased specificity. And what that translates into when it comes to a threshold is increasing your threshold number. And again, if you go back to the ROC data, I think this is very nicely shown here. As you take a low threshold for differentiating between patients above or below 70% stenosis, if you take a very low threshold here, you can see that our sensitivity is 100%. So at this rate, any patient who has greater than 125 or less than 125 stenosis, we would pick up all of the patients who have a 70% or greater lesion. Well, at what cost? Well, that cost is measured in specificity. We would overcall or send about 13% of patients on to either angiography or surgery incorrectly. They would have less than a 70% lesion. So as you increase your peak systolic velocity threshold, and again, the same applies to the ratio, you can see that the sensitivity begins to fall, and in fact quite dramatically, such that if you have a very high velocity threshold here, you would only identify 33% of the patients. Of course, conversely, you would almost never send a patient on to surgery in that particular case unnecessarily, or without having a greater than 70% lesion. Well, unfortunately, I naively thought that there would be some magical cutoff point, but if you look at these numbers, you can see that this absolutely increases gradually, this absolutely falls gradually, and so there's no obvious cutoff point here. So you really have to be the one clinically to make the decision. Again, how many patients are you willing to miss? How many patients are you willing to overcall? And that's where the clinical trade-off comes in. If you think about those patients in whom there is significant symptomatic disease, again, huge benefit from surgery. You should never miss one of those patients. And so for that reason, many of the more recent studies have chosen relatively low thresholds because, again, you do not want to miss one of these symptomatic patients who really will benefit tremendously from the carotid endarterectomy. Some people have actually taken this on to what may be almost an illogical extreme, or to the extreme where, and you can do this, and we've done it actually in one of our papers, you can actually calculate the stroke risk or even cost to society of strokes and then do a mathematical calculation and actually in this way arrive at an optimum threshold. And again, it's the same story, that because of the huge benefit or decrease in stroke risk or stroke in the symptomatic population, you can see here that again the optimum threshold here is going to be really, really low, based on, again, cost in the number of strokes or even cost in dollars for this. Whereas with the asymptomatic population, because there's minimal benefit to endarterectomy, the actual threshold falls not in one place, but in fact over a wide range, but does actually have a nadir here at about 225 centimeters per second. So we actually looked at a large number of patients who had angiograms, and who we then looked at the Doppler values and applied each of these different statistical methodologies to that same group of patients. And as you might imagine, each method actually did in fact yield a different threshold value. Peak accuracy actually gave us a single value, but again, you could change very greatly your thresholds with very little difference in the peak accuracy. Sensitivity and specificity and outcomes gave us a range. And remember, each of these methodologies does have an advantage and some disadvantages. So if you think about this sensibly, outcome is the ultimate thing that we're trying to achieve, good outcome or stroke risk reduction. So those numbers that we arrive at based on an outcome study should probably be number one. If you then apply sensitivity and specificity of greater than 90%, that would probably be the most reasonable secondary thing to keep in mind. And again, we can adjust among those ranges to try to maximize accuracy. And if you look at these numbers, what you see is that in the asymptomatic population, again, because of the tremendous benefit based on endarterectomy, the outcome thresholds that you would use are very low, between 125 and 175. Likewise, the specificity and sensitivity are in the mid-range, and again, accuracy, as we mentioned, is around 200. So you'd probably want to be at the very upper limit of the outcome range. Interestingly enough, if you look at the asymptomatics, you would logically have to choose a higher threshold because, again, here you want to err on the side of sensitivity, or rather specificity, and so, in fact, you would logically want to have a higher stenosis threshold. What's important to keep in mind here is we are not in any way trying to tell you that we are grading the degree of stenosis. What we're actually doing here is separating patients who would go on to endarterectomy or further imaging from those who simply do not need it. And unfortunately, that's really what all of the papers recommending thresholds have done. None of them have actually used a threshold to try to tell you how to characterize the degree of stenosis. So what do we do with all this? Do we throw it all out because it's just too damn confusing? Well, no, probably not. And in fact, I think our own body, the Society of Radiologists in Ultrasound, put together a consensus conference, which I was luckily asked to chair a couple of years ago. And if you can see the names on this, you will see that it's a very wide range of, I believe, experts. I think we have people from the technology world, we have people from surgery, vascular surgery, cardiology, neurology. It's a very wide range of people. And we all got together for 2 days and sat in a room and locked the door and said, you guys are not getting out of here until we come up with some consensus agreements on how to use thresholds. And interestingly enough, we did just that and left the room in really pretty complete agreement on what numbers would be reasonable to use. And these are the SRU consensus diagnostic criteria. They are in that article published in Radiology and are available. And I think these are very reasonable numbers. It's interesting, in fact, that this number here, the threshold for greater than 70%, is 230 centimeters per second, was actually recommended by Greg Mineta, Greg being the person who published that article on 325 as a threshold. And again, if you look at that article, there was a good reason for choosing 325. His was the first article that actually recommended or said that you could safely take a patient to endarterectomy based on the ultrasound values alone. For that reason, he chose an extremely high, unrealistically high, not unrealistic, but realistic for his purposes, but a very, very high threshold, because at that time he felt that he never wanted to send a patient to surgery unnecessarily. It's obvious over the years with experience now that, again, conversely, you don't want to miss a lot of patients with greater than 70% lesions because of the tremendous lowering of the stroke risk. So again, all of this is really a trade-off. These are excellent numbers that can be applied to any laboratory. And I think one of the things, just in closing, or the two things that I think I'd like you to take away from this chart, is that these, again, are good numbers that could be applied and reasonably used in anyone's lab. If you have internally carefully validated numbers, best thing to do is stick with them. Don't let anyone try to change you. But if you need an article or if you need a reference upon which to hang your hat so that you have good workable numbers that you might be able to tweak as you go, these numbers will serve you well. And they've served us well since we've had the conference, and I think many people have actually adopted them. I think the other thing to keep in mind about this is that, as I mentioned earlier, there are a number of parameters. Use as much as you can of the Doppler examination and the real-time examination to get to your diagnosis or estimation of the degree of percent stenosis. Don't just use a cookbook. And so the SRU group, again, we thought that the most important and easiest and most reproducible number was peak systolic velocity. And as you saw from my ROC curve, it works quite well. That should be your primary diagnostic parameter, but it should be coupled with an estimation of the plaque burden so that when you see a high number, does the patient have a concomitant or a confirmatory amount of visual plaque present? If so, that's further confirmation that your estimation of the degree of stenosis is correct. Bring into that then the ratio, or even the ratio and the end diastolic velocity. And again, the idea being that all of this stuff brings you unity, gives you a higher degree of confidence that you are correctly diagnosing that lesion in one of the recommended strata. And again, if you see one of these numbers that's out of whack, it's up to you as the diagnostician to try to figure out why. And again, I went into some of those reasons. But I think this chart has been adopted by many, many labs, and I think has served us well over the last couple of years. And again, hopefully many of you, if you haven't already, will consider using it. And again, I will close by saying, if you have good internally validated numbers, my congratulations to you, continue to use them, but that these numbers are good and will work in the general population of both symptomatics and asymptomatics, given the trade-offs that we have to deal with. So thank you.